TAVI across different age groups. What does the data say? I'm just giving you a flavor that structural heart interventions is now becoming more and more popular, and volume-wise also in India now we are gaining more volumes, and data is increasing. So that way we are sitting quite comfortably and doing all the complex cases now on our own. Initially we did it some with some proctors, but now the numbers at Medanta, we have done, personally I have done close to 100 TAVRs and TMVRs also, percutaneous mitral valve into the previously deformed bioprosthetic valve, and some mitra clips also is being done. So we are doing all kinds of structural interventions which is available now across the globe, and pretty happy to share this and present some of the interesting cases in our journey. So just presenting a very short few slides that I have also been intrigued by the fact now we say that TAVI is reserved for patients more than 65 years of age, and we follow it quite rigidly. But of late, I got few patients, and I have done practically, I'm saying around 50 years of age with aortic stenosis. And the reasons I'm going to share why we thought of that and why we have done that. So that is where the intriguing aspect came into my mind, that is it a really a foolproof age limit that lesser than 65 years of age TAVI should not be considered at all or should not be done? So that question percolated in my mind while I decided to do TAVI in those patients, and mind it, so these guidelines actually do not take into account many other aspects. So it's not an absolute, mark, the age mark, 65 years of age. There are many other things happening. So like I share one patient who was around 48 years of age. He had critical aortic stenosis, moderate AR, dilated LV, and EF of around 15%. And he was getting hospitalization repeatedly for 3 or 4 months, almost one hospitalization every month. Every time he used to stay in the hospital 5-7 days. So clearly AVR, aortic valve replacement, was the way ahead. But then with the kind of dilated LV he had and very low ejection fraction, he was a very tough candidate for surgery. He was a very high risk candidate for surgery. Although age was not a parameter by virtue of which we clearly decide that we go ahead with TAVR. So I kept the patient for surgical AVR. We waited, all the time we decongested this patient. He gets better after some days and then again lands up. The surgery team was doing their job pretty stringently, but still not finding a window where they can go ahead with the surgical AVR. So his PA pressures were high all the time. His LV was bad. So after 3 or 4 admissions almost, while surgery team was not taking a decision to go ahead with surgery, I discussed with the patient that why not TAVR. So I discussed with him very clearly that once we do TAVR, the durability of the valve is around 10 years as per the data available now. So there could be a repeat procedure which is required. But yes, the TAVR would do one thing very clearly. It's going to improve your LV. You become in a much better shape. And even if we require a procedure or repeat surgery after 10 years, I think the risk would be much lower. So this I'm saying I did TAVR in that patient. He's doing absolutely fine. He was around 100 kg guy. So after TAVR, his LV improved. Now he's exercising. He has lost weight. He's doing, his quality of life is very good. And this is almost 1.5 years prior. I have done that. So so this intriguing aspect from all this thoughts which came to my mind, whether the 65 years or 60 years of age is an absolute age group beyond which we should consider TAVR and not below that, I think, yes, in a generalized manner, we should not. But from case to case, the variability happens, and there could be heterogeneous case presentations like this, which I discussed. where still TAVR may be an option to save a life. So this is the journey of TAVR over 31 years. The idea actually came into being in 1990, and then the first series of animal implantations were started in 1992. And we all know Alain Cribier in France did the first TAVR in 2002. And then we have multiple trials, multiple data available from a very high risk subset to a moderate risk, and now to a milder risk, low risk category also it is applicable. So again, 2002 first human TAVR implantation, first US experience 2004, evidence of for extreme high risk patients. The trial was very clear, and there it paved the way for this procedure. 2012 to 2017 these trials were done. So then the intermediate risk and now the lower risk. So as far as this journey is concerned, I think this is a beautiful procedure, very patient-friendly procedure. Only limitation in the Indian scenario is one, the cost, and second, the durability of the valve. Now, this is the data which is very interesting. The significant growth of TAVR from 2012 to 2017. See, it was 15.4 TAVRs, almost 1 lakh per 1 lakh cases initially, and now it is almost 90.6 per 1 lakh. So there's a considerable significant growth of TAVR procedures happening all across. And on the other aspect, the surgical AVRs, the graph is totally opposite. 92.8 per lakh to 63.5 per lakh in 2017. So it's a totally reverse graph. And this is the ratio of TAVRs and versus SAVRs over the time basis on age groups. So this is also depicting the same scenario from 2012 to 2016-17. Among the beneficiaries, more than 85 years of age, TAVR. So practically, the data is very clear. The journey of TAVR has been really enthusiastic, really encouraging, and the results have been really good. So this is the guideline. This is what I was trying to point and leave it to all of you with a thought process that patient age, definitely it matters. Less than 50 years of age, we actually should not consider TAVR and should consider a mechanical valve, keeping the durability of the valve in mind. But then more than 70 years of age, clearly it's a TAVR way, and there is a gray zone between 50 to 70 years of age. And now if in this gray zone also, if the decision is towards a tissue valve, because of some issues with the individual, because patient has some bleeding tendencies and cannot have a long-term anticoagulation, then obviously the tissue valve. And if the tissue valve, again, it goes in favor of TAVR. Only thing is, if it is a mechanical valve up till the age of 60 years of age, then it goes in favor towards a surgical AVR, keeping in view the duration of the valve. So young age does not equal low risk for patients needing aortic valve replacement. This is what actually I mentioned, and I depicted one case. So this is all a thought process which, as cardiologists, keep on going in our minds on daily basis once we handle such sick patients. And it is very important. And definitely another important aspect to have a good decision is a heart team approach. So we should not be biased. So it has to be in conjunction with the cardiac surgeon and at times a cardiac anesthetist also, because patient may be having lung disorders which make the patient high risk candidate for surgery, or maybe having some issues because of where the ventilatory things become very difficult. So this is on a philosophical level that we should think of all these points before finalizing that which is the best strategy for a patient. What does it take to plan a TAVR case? Infrastructure, a heart team, a suitable patient, obviously, a necessary hardware, a valve technical specialist, and for newer guys who are starting this process, doctors. And I'm privileged to announce that I'm a proctor for both Medtronic as well as the Merrill. So how does a typical TAVR case like? A CT evaluation is very essential, which tells us about all the parameters. As we go along, we keep discussing about these things in more detail. Once I say as we go along, as we go along in the more monthly meetings, hearting discussion, and all the parameters of the particular case. This is very important. There are some red flags which we should know, and we'll discuss in probably in the next presentation that what is the CT analysis, which we should we should know exactly that this is a favorable case for TAVR and these are the red flags. So we'll discuss about the CT findings to plan a TAVR case, favorable and unfavorable aspects. So this is the patient I'm showing, a very simple patient today, but we have done a whole range of TAVRs in all the complex patients, be it a bicuspid valve or a unicuspid valve. So particularly, I have done around 3 unicuspid valve TAVRs, which is quite a rare thing overall globally, but somehow I have done 3 unicuspid TAVRs, and then a TAVR with a horizontal aorta, highly calcified aorta, and we face many difficulties, but we'll be discussing all those. So initially, this is a 76-year-old male, severely calcified aortic valve, AVA of 0.9, and mean gradient of 50, normal LV, mild MR, mild TR, KFT normal. So this at 76, this patient is very clear favorable candidate for TAVR. And then CT evaluation, as I mentioned, is very, very important. And this is how, the CT tells us about the annulus. The first picture is of the aortic annulus. It tells about the aortic annulus. Aortic annulus is a point where the radiologist goes a little bit down where all the cusps are visible. So once we have to take a dimension of aortic annulus, it is the point where no cusp separation is visible. So just below that. And then this is a sinus of Valsalva where it's all the cusps are visible. And this is how it looks. See the calcium and then LVOT dimensions. So this is very important, whether this is in parallel, whether LVOT is smaller or larger than aortic annulus. This also helps in taking a decision. Sinotubular junction and then coronary height from the annulus, extremely important. This is less than 10 millimeter is a red flag, and we should plan our strategy accordingly if the coronary height is less than 10. So all these points on CT analysis is very, very important. Plus this, the femorals, the curvatures of common femoral and common iliacs, the calcification around these vessels, and the caliber of these vessels. And then this is how the procedure is done. We take a puncture by taking a contralateral femoral angiogram. This is a femoral angiogram done from the contralateral side, and puncture is taken based on a CT picture and where we know exactly where the profunda is arising over and above that. So in case here, just here around the femoral head should be a puncture. So there is a technique of having a puncture which we keep discussing as I mentioned. So after this, we take an aortogram, and two wires, we cross the valve. Once we cross the valve, we keep one pigtail into the aortic sinus and another wire into the LV, from the aortic valve into the LV. And then as a first step, prior to the valve deployment, we pre-dilate the aortic valve, do the balloon valvotomy, and sizing we have already done in CT. So based on that sizing, we take a valve in question. So this is a Evolut R, the Medtronic valve, self-expanding valve, very beautiful valve, and it's very good in terms of the outcomes, because here the valve actually is lying in a supraannular position. So it gives a better orifice areas, even far better than the surgical AVRs, because it's a supraannular valve. So this is how the deployment is done. We start unloading this valve by counterclockwise rotation at the hardware, which is outside with us. And slowly and gradually, we keep on coming up till this point. So at certain point, almost where this starts opening at this juncture, the blood pressure tends to fall because the newer valve starts to function here. And then we require to rapidly, unload this valve up till certain point, up till a point where still it can be retrieved. So we reach this point, and now there is no issue. Now the blood pressure settles, and we wait until we wait for 5, 7, 10 minutes at this point, because valve keeps on expanding a little bit and it takes a shape, and there is no hurry, there is no rush here, and we wait for some time. And once we are sure that it is not popping out, it is actually covering all the annulus. And then if we are sure that we are some distance lower than the annulus, we can deploy this valve slowly and gradually. And this is how it is done. See, the next video shows that it is being deployed. And this is a final aortogram after this valve is deployed. And see, it is now quite symmetrical. All coronary is working fine. And as I mentioned, because of its supraannular valve inside this rim, it gives very good orifice areas, and the results have been pretty gratifying. So we check for aortic regurgitation, we check for gradients in echo as well as on cath, and if we are comfortable, this is the end of the procedure. So over the time, now we have done quite a number of TAVRs. Our time duration for this procedure has now come to almost 1.5 hours only. Initially, however, it used to be 4 hours. We are doing all the procedures under conscious sedation, no general anesthesia. We are not doing any cut downs, one ProGlide or two ProGlides, but I use one ProGlide and one angio seal at the access point, and we seal it now fairly responsibly without any complications down at the access site. So it's a highly patient-friendly procedure, that is my word. And except for two small things which are attached to this procedure, one is the cost is a bit high, and the durability. So we are not considering it this in less than 55 years of age, but barring few subjects which still can fall into that zone. That's the message for today. And keep it a thought, give it a thought that how the guidelines may not actually take into account all those parameters where we may have to consider TAVR even at a relatively younger age because of the very high risk.